Good afternoon, everybody. Good evening. Good morning. My name is David. Here's my partner.
My name is Odunayo Talabi.
Today, we'll be introducing to us our curriculum, Reducing Measles Transmission in Gaines County, Texas. Our program is a school and clinic-based measles, mumps, and rubella, also known as MMR vaccine uptake program. The measles resurgence has been going on and is one of the most contagious diseases and vaccine preventable diseases. Globally, in 2003, it had 10.3 million cases, and in the US, we achieved measles elimination in 2000. However, recent outbreaks linked to the MMR vaccine coverage has caused an immense amount of problems domestically and locally.
And as David said, that the current outbreak in the United States um, is a new trend, considering that the vac the measles infection uh, was previously eliminated in the United States. So our program is to focus on the hotspots in the US. For instance, we know that Texas currently reports the highest measles incidence in the United States. But not just that, although Texas is a border state, and we would expect that perhaps this is because of border activity and maybe travelers uh, bringing the infection into the United States. But this is not proven. And in fact, we discovered that in Texas, Gaines County is the region with the highest cases in Texas. And then not only that, this has been found, the infection has been found to concentrate in some specific localities that share things in common, like uh, high rate of vaccine hesitancy and um, high uptake of the state exception policy, because Texas is one of the states where we have the exception policy and people can refuse vaccine on ground except medical grounds. And because of this, many people have refused to give this vaccine to their children, and also in some instances, people's religious belief is also a factor in this. And because of this exception policy, many children in the age group that should take MMR vaccine, which prevent measles, have not taken it. We have an example of a particular district where almost half of their students hold vaccine exceptions, which means that they are not going to take the vaccines on other reasons aside medical reasons. So, in order to back up our program rationale and confirm that really we have something that is going on in tandem with what we were suspecting, then we conducted a needs assessment, which was divided into two. And our findings were also broken into the two, such that quantitative and the qualitative. I must say that in terms of qualitative, there are anticipated themes, in the sense that we were not able to enter the community yet to speak with people. But starting with quantitative, we did a literature review, and it was confirmed that the rate of measles infection in the United States is rising, and there are some parts of the country where we have higher rates than others. And like I've said before, vaccine exemptions is one of the things that uh, that are contributing to this. The same also is rural healthcare access. So people who live in rural areas do not have ready access like those who live in the cities. And that has been found to be a factor as well. And because of what we know about the community, we were able to also extrapolate the qualitative likely expectations because we have a religious group, the Mennonite community, who hold a slightly different view of vaccination. And because of that, their interpretation may be slightly different from the mainstream knowledge or acceptance of vaccines. So they have limited trust. And then some of those things are also cultural norms, things that they've come to regard as normal. And what this does is that it's not only increases the rate of infection, it also increases the rate of transmission, knowing that measles is a highly contagious and transmissible disease.
Therefore, our mission statement is that the mission of this program is to reduce measles transmission and restore community immunity in Gaines County through culturally tailored MMR vaccines education and access. In addition, our priority population or target population are parents and caregivers of children, specifically preschool to kindergarten through grade 6, as well as unvaccinated or under-vaccinated children. Also, communities with low vaccine confidence and rural families with limited health care access. These are all communities that are underserved and are at high risk for measles infection.
Thank you, David. So our program goals and key objectives. And then as we know, it's important in public health, especially in health promotion, to conduct a needs assessment, and then we set up our goals. In this case, we did just that. And then our long-term goal is to reduce the incidence of measles in this county, in Gaines County, by half by the year 2029. And then how do we want to achieve this goal? We also have some key program objectives that would help us to achieve this milestone. And one of them is we want to improve the knowledge of measles severity and vaccine safety amongst this population and this community. And we want to increase their confidence in the MMR vaccine. That is by dispelling their fears of side effects and, of course, dispelling myth and misinformation that might have spread, especially during COVID, where a lot of misinformation about not just the COVID vaccine, but about vaccines in general were spread. And then we want to focus on this objective of trying to dispel this myth and then explain to people why it is important to get this vaccine. But not just that, we mentioned those in the rural areas who do not have access. So sometimes their case is not hesitancy per se, it's really just that they do not have access to this. And then, so one of our objectives is to improve access. How do we do that? We're going to consider uh, mobile vaccination effort, and other things we are going to discuss as we move forward in this presentation. And then, of course, we want to increase completion rate among children of the age group that should take this vaccine. I mean, I'm talking of between 1 year and 6 years when they should take the first and the second doses. So these are objectives towards achieving a long-term goal for this program. And then we have theoretical frameworks. Like I said before, in public health and health promotion especially, uh, theoretical frameworks are like building blocks. They are things that give our program structure because they help us to not only plan the program, but also to implement the program and then to evaluate it. So they help guide us, even sometimes to determine and know which resources we are going to need in terms of financial and human to conduct the program successfully. And then we are going to make use of three of those theories at different points in the program. For example, starting with the generalized model. For this model, we are going to use it for the overall program pre-planning and planning, because then such as um, entering the communities, speaking to stakeholders, in terms of caregivers, in terms of school administrators, and in terms of even the health practitioners or providers in these communities. We want to approach them and then from there identify needs, discuss on how we can tackle the needs, because we also want the insight from the people in the community, which would help us to know how best to solve the problem. So from there, we want to now plan the exact implementation and then evaluation, just as it is in the spectrum of the generalized model. And then another theory or model we want to use is the health belief model. Now, this model helps us to understand people's behaviors. We want to know, why do people do what they do? What makes people uptake the vaccine for caregivers in the same community who agreed to give their wards vaccine compared to caregivers who did not? And then we want this to be explained by looking at the different domains in this model, which is perceived barriers, susceptibility, cues to action, and so on. And of course, the logic model. We want to use that to link program resources and activities to expected outcome. And we are going to talk more about the logic model, particularly in adopting it to our program as we move along.
Thank you. So now I will be introducing to us briefly about our program elements. Some specific activities will include school-based parent education forums. Here, we will allow the parents to share equally with each other their concerns, their questions, and most importantly, provide solutions. And this is also going to apply in the clinic-based Ask the Nurse evenings. Here we have nurses and possibly physicians where they will provide detailed medical related questions, uh, answers to the questions the public would most likely have. And in addition, we will have mobile vaccination events like Dr. Talabi mentioned, my partner, uh, such as mobile clinics where we can bring the convenience to the public. They don't have to travel, let's say, 20, 30 miles. I have the I had the privilege to work in rural Oklahoma, and similarly with Texas, a lot of times the public need to travel long distances in order to get themselves vaccinated. This could and is a major barrier and obstacle to vaccination. Last but not least, one of the major points is to have a parent ambassador program where we will selected parents will be the appointed ambassador to spread knowledge and raise awareness regarding vaccine prevention and promote this idea to the general public. And here is our program's logic model we were talking about earlier. We will have inputs such as public health nurses, like one of the previous slides, speak to nurse evenings, similar events like that. And then uh, I also mentioned that we will most likely have doctors and pediatricians, and as well as faith leaders, most importantly, health educators, and tailored education materials to the specific communities we are prioritizing and targeting. Activities include school-based parent forums, as we also saw in the previous slide, clinic ask the nurse evenings, mobile vaccination events, etc. And we will expect outputs to be conducted forums, such as parents, number of parents reached, clinic evenings held, etc. And short-term outcomes will include increased measles MMR knowledge, reduced belief in vaccination myth, and improved vaccine confidence. That's one of the most important outcomes in the short run we want to achieve. And some of the intermediate midterm outcomes will be the increased appointment schedules and the increased appointment scheduled and attending services in terms of vaccination, increased MMR series completed. This is also one of the most important steps because, like the hepatitis vaccine nations, they have a series participants need to follow. Missing a dose or more is detrimental to the overall vaccine because potentially in those cases the vaccinations will not be effective. And ultimately, the long-term outcomes will include 50% reduction in measles incidence from the year 2026 to 2029. That's what we finally want to achieve, and as well as the restored community immunity for better health outcome and a better healthier lifestyle in the long run.
And this really shows that, looking at our logic model, that we are going to have uh, to interact with the people in this community at different points in time. We are going to need them to attend our meetings. We are going to need them to call in, and we are going to need them to tell others for parents who have taken the vaccine for their kids. So this just means that we need to co-create this program with them at every point in time. And I can give an example of a typical program that we are going to conduct. For example, we want to have a session in the school that would have a faith leader from the Mennonite group in attendance. We are going to have community stakeholders, people who are like mentors and influencers in the community. In attendance, we are going to have health personnel, either a pediatrician or public health uh, educationist. And then we are going to also have the school nurse, the school administration. The goal is to, and then the caregivers, of course, the goal is to bring everyone together and then let us have a discussion on the barriers that uh, are perceived or real, and then, of course, the facilitators of this vaccination program. Our aim for this type of program is to ensure that at every point in time, we are co-creating these solutions with the community, and then also we are collaborating on whatever interventions we are going to deliver to the community. And you agree with me that this makes it really, really important for us to have cultural integration strategies, because then we need to be culturally humble uh, and approach this with cultural humility, with the intent to learn from these people. I feel if we do that, we are likely to hear their pain points, and then we are likely to be able to create a solution that works with them. So, and the effort we are going to make in terms of this strategy include plain language educational materials, free of medical jargons or public health jargons that they are not likely to understand. And then, of course, like I said before, we are going to collaborate with people they look up to in the community, because we know that studies have shown that for people to uptake any vaccine, it needs to be introduced to them by those they trust, either in terms of their providers or in terms of their community leaders, sometimes even in terms of significant others, before people would agree to take the vaccine. And then we want to frame our message around what matters to them. I mean, these are caregivers, these are mothers and fathers of little children who want their children to be well. But beyond that, they also share a sense of community. They want their community to be upheld. They want their community to be healthy. And we are going to frame a message around this cultural item that matter to them. And then, of course, we want to hear them in terms of our meetings, in terms of our calling programs, in terms of even the mobile vaccination effort. At every point in time, we want to get the parents or the caregivers together to share their ideas, and we also want to get them together alone if they desire that and they want to speak privately. At every point in time, we want to provide this opportunity for private discussion and also public discourse to to push this forward. Overall, we are going to respect their culture, and then we are going to work with it in a way that will favor them. And at any point, if we need to interpret, we plan to get interpreters within the community who would also help us to spread our message. And then we want to evaluate our program. At the end of it all, we want to know that how effective has the program been? Because we want to also learn from this program and then probably use it to scale the program, hopefully, if it's successful, or to plan new programs, either for measles vaccines in other countries, in the US, or in any other part of the world. So, in evaluation, we are not just going to look at what has changed, we also want to see uh, was it our program that changed those things? Or how much of our program contributed to the changes we anticipate seeing in another, in a few months or a few years. So, and then our evaluation plan is going to start with the process evaluation. We want to track our program implementation. And this is going to be very early on. And in fact, during the program itself, we want to, at every point in time, after our first parent teachers program, we want to assess what went right, what we could have done better. And then we plan to use that to improve the next program. How do we get people to come? How do we ensure they're comfortable? How do we ensure the message is passed? And how do we ensure that we're able to get the feedback we need? Those would be things that will be in process evaluation. And then we're also going to have impact evaluation. We are going to give out surveys. We are going to look at vaccination records in clinics, in primary healthcare centers to know has it improved, and then how much of that improvement is due to our program, and how much is due to other things that are happening in the county or the country at that time. And then we want to do outcome evaluation. Over time, we want to know do we have reduced incidence of measles in this county? Do we have more community immunity uh, as a result of more children taking their vaccines on time? All these are going to go into our evaluation plan. The purpose is not just to prove that our program succeeds or not. The purpose really is to see that uh, what has worked, and then what knowledge can we share with other parts of the state of Texas, and of course with the country overall. And then hopefully we are able to disseminate this information in different forms, and then we're able to know what exactly worked and can be again replicated for future programs.
Thank you. So, the expected public health impacts will include the improvement of community vaccination confidence, such as we mentioned before. The community would be more united and believes in the vaccination more. We want to get rid of the vaccine myth from the general public. In addition, we want to increase the MMR vaccine uptake. Of course, that's going to be as a follow-up with the very first point, because when they have raised knowledge and awareness, similar actions, health enhancing actions will follow. In the intermediate term, we will restore the herd immunity. This is where a majority of the general population is uh, vaccinated and they have the immunity to fend off the virus for potential transmissions. We also want to reduce measles transmission, just as I mentioned a second ago. Therefore, overall, we will strengthen the community public health partnerships within all the above mentioned entities. Here are our references. Thank you very much for tuning in. And if you have any questions, please feel free to leave us a comment or shoot us an email. We will leave our contact information down below, and we will also respond to you as soon as possible. And we are confident that from the year 2026 to 2029, that the incidence rate of Gaines County, Texas, in terms of measles, will be successfully reduced by 50%. Thank you. Have a great evening.
Thank you so much, everyone.